Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist for 40 years from the Houston area. The focus of this presentation is ACC AHA 2022 Guidelines for COVID-related myocarditis and other sequelae. I got interested in COVID-19 back in March 2020 when I was in Temple, Texas, and I wrote more than 100 articles on the topic of COVID in the Facebook Physician app. And after that, I wrote this book, COVID-19 Pandemic, an international guide for future pandemics. So that is my background as far as COVID is concerned. So I have been deeply interested in COVID from the time it just arrived in New York City on, say, probably March 1st, 2020. And I have followed that very, very keenly over the past 2+ years. And I also looked at the exact pathophysiology of what destroys the lungs and what destroys the heart, and we're going to cover a lot of this information with reference to the heart in this presentation. This is based on the ACC 2022 guidelines or expert consensus on cardiovascular sequelae related to COVID in adult population, and we'll learn a great deal about how COVID myocarditis and other sequelae manifest and what we can expect if one of our patients has this or one of the family members has such a incident. Basically, COVID SARS-2 virus attacks the epithelial and the endothelial cells. In the process, when it destroys the endothelial cells, it not only destroys the cells, it also creates microemboli within the microcirculation, which leads to microinfarcts in the lung tissue, leading to alveolar destruction, and in the kidneys, leading to kidney glomerular destruction, and also in the heart, it leads to microvascular dysfunction, microvascular emboli, microvascular thrombi, that leads to necrosis of the myocardium, leading to patchy areas of myocardial destruction that results in cardiac symptoms like chest pain and reduced cardiac function. So these patients manifest with what we generally call as inflammation of the myocardium, which is actually like a vascular pathology. And it can also involve the pericardium, leading to pericarditis with the widespread destruction of the myocardial fibrils. It can lead to cardiomyopathy, and I already talked about thromboembolism. And because of myocardial inflammation, they may be prone for cardiac arrhythmias, and also because of the myocarditis and myocardial dysfunction, they are prone for symptoms of heart failure. Majority of them recover within 3 months, and they can return to play or return to work. And this is especially true in younger athletes who develop clinical evidence of myocarditis as presented with symptoms and positive biomarkers. Then we have to decide when they go back to the physical activities, because if they are a professional athlete, it becomes a major concern. Sometimes patients may continue to have lingering sequelae, such as chest pain, palpitations, exercise intolerance, malaise, dyspnea, and a whole host of other symptoms. So let us explore further. 78 million people have been diagnosed to have COVID in the United States. We have close to 1 million deaths as of this day. The incidence of myocarditis in the COVID population, according to the CDC, between March 2020 and January 2021, patients with COVID-19 had nearly 16 times the risk of developing myocarditis compared with the population that did not have COVID infection. And this is much more so in the population less than 30 years of age. And as I said, this predominantly affects males in the age group 19 to 29. The incidence of myocarditis is 40.6 cases per million vaccinated people. So not only do we see myocarditis in patients with COVID infection, there is an increased incidence of COVID in patients receiving messenger RNA vaccines. It is 40.6 cases per million in people who are between 12 to 19 years, while it was 2.4 per million in males over the age of 30 years. So predominantly it is seen in young adults, and it becomes a concern if we are talking about sports athletes. The hallmark of myocarditis is infiltration of the eosinophils and destruction of the endothelial cells in the capillaries, leading to microemboli, thrombosis, and also destruction of the myocardial fibrils along with coagulation necrosis. There will be microvascular dysfunction, all these things leading to cardiomyopathy and cardiac arrhythmias. A couple of new terminologies as far as COVID-19 myocarditis is concerned, that is PASC, which stands for post-acute sequelae of SARS-CoV-2 cardiovascular disease, all these things which I mentioned. Now, post-acute sequelae of COVID-19 cardiovascular symptoms would be chest pain, palpitations, exercise intolerance, postural hypotension, tachycardia, and other types of arrhythmias. And of course, we talked about microvascular dysfunction. RTP refers to return to training program, which is particularly of importance to the athletes. The diagnostic tests that are routinely used in these patients who present with symptoms of chest pain, palpitation, shortness of breath, or fatigue, the tests would include electrocardiogram, where we can see some minor STT changes, echocardiogram, which may show evidence of pericardial effusion, and cardiac size and left ventricular ejection fraction, chest x-ray, which may show infiltrates in the lungs if the person has pulmonary involvement, and of course ambulatory monitoring for those patients who have tachycardia or palpitations. The most important one is of course the high sensitivity troponin N along with CPR. Troponin N is very sensitive in terms of diagnosing myocarditis, but it doesn't tell us if it's myocarditis or pericarditis, because pericarditis is usually associated with some degree of myocarditis. And chest CT and CMR are quite useful in picking up myocardial inflammation, especially the CMR with late gadolinium enhancement. We can look for patchy areas of myocardial necrosis, inflammation, and scoring. Of course, pulmonary function tests if they have significant pulmonary involvement. The treatment options available for these patients are anti-inflammatory agents if they are having symptoms of pericarditis and chest pain. Colchicine would be another useful option. Some of these patients may need either oral or intravenous steroids if they have active myocarditis. If they are having arrhythmias, they need antiarrhythmics. Beta blockers are useful, but beta blockers should be used with caution because these patients can develop hypotension, and they are prone for orthostatic hypotension and orthostatic tachycardia. Calcium channel blockers and ibuprofen can also be used, and midodrine can be used if they have postural hypotension and postural symptoms. Once they recover, they can go on a programmed exercise regimen and rehabilitation. Here are some of the flowcharts from the ACC AHA 2022 guidelines. Early symptoms include fatigue, decreased exercise capacity, excessive tachycardia, and orthostatic intolerance. And the symptoms could be very mild. Some patients may be asymptomatic, and some patients may have severe symptoms, and maybe about 5% of them go on to develop significant cardiac failure or maybe cardiomyopathy. And we talked about the age group, and this is supposed to be an immune response to the antibodies from the virus. Worsening of symptoms can include limitation of exercise capacity, post-exertional malaise, decreased quality of life, and inability to work. They may have cardiovascular deconditioning because of reduced blood volume, reduced cardiac output from myocarditis, and reduced ejection fraction, along with decreased stroke volume. Many people are asymptomatic, or they may have mild non-cardiopulmonary symptoms, or they had an infection more than 3 months ago. If so, they need no further cardiac testing. On the other hand, if the patient is having symptoms of chest pain, maybe some dyspnea on exertion or palpitation, an electrocardiogram, cardiac troponin, and echocardiogram would tell us if we are dealing with a case of an acute myocarditis. If the tests are normal, additional cardiac testing, if it is needed, then we can proceed. Otherwise, we can, if it's abnormal, then we consider cardiac CMR, look for areas of myocardial inflammation, myocardial necrosis. Then we can recommend additional tests based upon PSCA. The diagnostic sequelae, we look for myocarditis and other myocardial structures around the heart, namely pericardial effusion. Talked about post-acute sequelae of COVID, cardiovascular disease, and cardiovascular symptoms. And return to exercise management, I talked about people who had active myocardial involvement should not exercise for 3 to 6 months, and they should be under the supervision of a cardiologist, and they need to be followed up by cardiologists with follow-up echocardiograms or other tests to determine their cardiac function before they can return to vigorous exercise training. Then this chart tells us about if we are thinking about cardiac involvement, how do we proceed? And if there's no cardiac involvement, no testing is required. So I'm going to expand this section and see what we can learn from this. Okay, here's the chart. Of course, we do the cardiac initial diagnostic tests, and concerning EKG abnormalities, elevated troponins, we need to get a cardiology consultation. If the patient is clinically stable, we can consider a cardiac CMR and treat them with non-steroidal anti-inflammatory agents, colchicine, and once their symptoms resolve, they can be followed as an outpatient, and they can return to regular activities 3 to 6 months after an acute bout of COVID myocarditis. If the patient has a high-risk features, they need to be referred to advanced heart failure center, where they can do like endomyocardial biopsy and confirm myocarditis. And if they have severe myocarditis, they can be treated with steroids and also with ACE inhibitors to reduce the amount of myocardial damage and myocardial remodeling. And some of these patients may go into cardiogenic shock, and that's why they need to be referred to heart failure centers. And if they are having mild to moderate myocarditis, they need to be hospitalized. They need to be followed very closely by cardiologists and treated appropriately. If they have evidence of reduced ejection fraction, they need to be on ACE inhibitors, as I mentioned. If they have normal LV wall motion without any LV abnormalities, additional testing would be based upon their other clinical presentations. Like if they are having chest pain, pulmonary angiogram may be looked into. If they are having severe hypoxia, coronary angiogram if there is a suspicion of coronary artery disease or a pre-existing history of cardiac problems. As I mentioned to you in the beginning, in the population that is vaccinated, there is an increased incidence of myocarditis. In 1 million male individuals between 12 to 29 years of age, there were 39 to 47 more cases of myocarditis in the vaccinated group. But at the same time, the vaccinated group had 560 fewer hospitalizations, 138 fewer ICU admissions, and 6 fewer deaths. So the benefits sort of far outweigh the risk that we might encounter by vaccinating the population, especially between the ages 12 to 29 years of age. The mechanism of myocarditis, reduced myocardial function, pericarditis. I already mentioned these symptoms, and they are probably immune response to the virus and destruction of the endothelial cells and microvascular system with microthrombi leading to microinfarcts. All of those things play a role in the overall presentation of myocarditis, reduced cardiac function, reduced stroke volume, and the other things which I talked to you about, along with tachycardia, palpitations, and exertional dyspnea. Here is a comprehensive summary of all the things we talked about. I'm not going to go through each one of these. We have covered each one of these in the previous slides, but this is an excellent way to get an overall picture of how do you proceed dealing with a patient with suspected COVID myocarditis. A couple of words about orthostatic vital signs. We should monitor their blood pressure and pulse while lying down, while sitting, and while standing. If they have significant postural hypotension associated with tachycardia, they may be treated with the midodrine, which will help to increase the vascular tone and thus improve their symptoms. Of course, we need to pay attention to post-acute sequelae of COVID-19 in terms of cardiovascular disease and cardiovascular symptoms and treat them appropriately. All these things, the diagnostic tests and the management, are covered in this slide. So there is a 12-week exercise program that has been designed for COVID patients who have myocarditis, and this is a good way for athletes to get into this program, develop some strength and endurance before they go and resume their athletic training. Again, this one sort of summarizes what we have mentioned already. They are asymptomatic. They just need to isolate themselves for 3 days and can resume their routine activities. They have mild or non-cardiac symptoms, which was covered in the previous slide. So this is again a summary of what I have talked to you about, doing EKGs, troponins, echocardiograms, and if they are abnormal, doing a CMR, looking for myocarditis. If they have significant symptoms of heart failure, they need to be transferred to heart failure center. So ladies and gentlemen, this is a quick overview of COVID-related myocarditis, COVID vaccine-related myocarditis, how patients present, at what age group, what are their symptoms, what are the things we look for, and how we manage these patients and get them back to normal life. Thank you so much for watching this presentation. I have a series of ACC AHA guidelines on a variety of topics in cardiology. Please do watch them, and I will see you in the next presentation.